Audio recording for this meeting has begun.
Good afternoon, everyone, and thank you for joining us for the very first webinar for et al., the NCSD Journal Club. My name is Leandra Lacey, and I'm the Capacity Building Manager for the National Coalition of STD Directors. My hope is that this Journal Club will not only help to keep you abreast of current STD literature, but also that you can use the findings from articles that are presented and apply them to your own STD program. This is just a reminder that this webinar is being recorded, that the recording will be made available within 1 week of this presentation. If you have questions or need any technical help during this call, you can utilize the chat function in the bottom right corner of your screen. And you can also send a direct message to my colleague Neil, who is listed at the top of the attendees bar. You just right-click and then start private message to send him a message. All questions will be addressed towards the end of the webinar, but we will keep a queue, so please send them our way as they come up. I also want to flag for you that there's a box called Files on your screen to the right. In this box, you'll find the journal article presented in case you need to download it and reference it during the webinar. As I previously mentioned, the purpose of this journal club is to not only help keep you abreast of current STD research and literature, but through engaging discussion, you will learn about the implications of the literature on the STD program in your jurisdiction. Articles chosen will vary and may, for example, include research on progress in STD diagnostics and new treatments, an emphasis on health equity by focusing on populations that are disproportionately affected by STDs, etc. Each month following a webinar, a blog post will be shared via the NCSD STD Weekly email and on our website, where an author or authors of the previous month's article will answer a few questions regarding the article's implications for current STD programs and practice and other related areas they feel need to be further researched or explored. For our agenda today, we will start with an introduction of our presenters. We will then move into the article background, methods, and results, followed by a time for discussion and engagement with the presenters and participants, you all. There will also be ample time for questions for the presenters at the end. As a result of this webinar, participants will be able to, 1, describe the major sections of the journal article that is presented, like the background, methods, and results sections, and also identify the journal article's implications for their state STD program. So without further ado, I'll let our presenters today, Dr. Phil Chan from Rhode Island, Tom Bertrand, also from Rhode Island, and Daniel Daltry from Vermont, take the floor to discuss their article regarding partner notification services in New England.
Okay, so I'll jump in here. This is Tom Bertrand. I work at the Rhode Island Department of Health, and I want to welcome everyone to the call. I also want to thank NCSD for giving this journal article an opportunity to be discussed nationally. So a research article was published. It was led by Sarah Magaziner and Dr. Phil Chan with a great deal of input from the New England states. And so I thought what we would do on this call is to start it off by discussing the genesis of this article, and especially the importance of that the questions, the research questions, were actually surfaced as a result of a conversation, a regional conversation amongst STD directors in New England. So the title of the research, Public Health Opportunities and Challenges in the Provision of Partner Notification Services, the New England's Experience is the journal article's title. Today speaking is Dr. Phil Chan, who actually headed up the research, and we'll be talking about the meats and bones of it. I'll be giving the background, and then my colleague Daniel Daltry in Vermont will be heading the discussion session, as well as providing some input on the background. So just a little bit of background. About 3 years or so ago, the New England states, which include Maine, Vermont, New Hampshire, Massachusetts, Connecticut, and Rhode Island, decided to form an informal group called the New England Public Health STD Consortium. This was, the leadership was from Dr. Lynn Sosa from Connecticut, who had established a previous consortium on tuberculosis. So what we did was we decided just to begin having conference calls once a month to have conversations around STD control and how we can work together better in our region. I just thought I'd just do a plug for the New England region. We are the home of Tom Brady, as well as Ben & Jerry's, Dell's Fruit, and some great waterfront and clam chowder. So the purpose of our group, we formally decided, let's at least put on paper what the purpose of our consortium is. First of all, just develop regional STD prevention efforts, share programmatic and epidemiological information, do problem solving and technical assistance, and address the growing rates of STDs. And the rationale for our group at the time, and why we were somewhat struggling, to be quite frank, is that we were all experiencing decreasing federal funding for STD programs. We have a fair amount of cross-state travel of high-risk individuals. That includes a focal point of sexual activity related to summer tourist attractions, such as Provincetown on the Cape, popular bars in Springfield and Hartford, and other high-risk venues that might include bathhouses. We have comparable population demographics. Although we're generally a small region, I think relative to the rest of the country, we have northern New Hampshire with Maine, New Hampshire, and Vermont that have very similar characteristics, as well as what we call southern New England, Connecticut, Rhode Island, and Massachusetts. As a group, too, we're identifying that traditional STD prevention efforts were not as effective with emerging populations and the advent of cell phone technology. I think this is a given for many of us that we've experienced many changes with evolving technology and how people are choosing to meet partners and how to do partner services. We want to share best practices across states. I think some states are doing some really good work. We want to learn from each other. Many of us said we can use all the help we can get. We don't have a lot of tools in our toolbox. And also, we're also working against an increasing STDs rates across the region. So I thought I'd just share with you very briefly. We combined our numbers for the 6 states just to look at trends. And these are very simple bar charts. The y-axis is the number of cases, and the years go back 5 years. And you can see there for chlamydia, overall, this is for all 6 states, is up roughly 12%. Trends in gonorrhea for all New England states is up almost 60%, and trends in primary and secondary syphilis are up almost 70% across the New England region. So clearly, we have our hands full with a lot to address in terms of preventing new cases. So in terms of our collaboration, one of the important things is that we purposely included partners outside of STD programs and departments of health. This is a picture of some of our partners and some of us, but I have the list there of our state health departments. All of us participate. We also reach out to regional centers and programs, including Brown University AIDS Program, Department of Health and Human Services, the local PTC, the Sylvia Rattel Training Center, Yale, CIRA, Lifespan, and others. And then also, at times, both CDC and NCSD has participated in our calls. And the key for that was that as an outcome of that, when some of our partners heard about our challenges, they said, maybe we can help and contribute and participate in this group so that we could assist you in moving forward. And that's the genesis of how this project actually got off the ground. I'm going to pass it over to Dr. Phil Chan, who was part of our group and took the ball and ran with it. So Phil, I'll transfer this over to you.
Great. Thank you, Tom. And good afternoon, everyone. As Tom mentioned, I work closely at the Rhode Island Department of Health. I also serve as medical director of the single STD clinic here in Rhode Island as an infectious disease specialist. So Tom mentioned the background and a little bit about the EPI. The methods of the study really involved an online one-time survey to leaders from the health departments and the various STD divisions. We were able to engage and talk to and get input from all the New England states, Maine, New Hampshire, Vermont, Massachusetts, Connecticut, and Rhode Island. I will say the data and the survey was conducted in 2015, so it is almost 3 years old now. So I would keep that in mind. Certainly this is a developing topic, and things have changed. I'll try to update different practices, as I know, from Rhode Island, and Tom and Daniel at the end. Certainly, if there's any other updates from our states, please feel free to chime in. And if there's others on the call at the end, there will also be an opportunity to chime in if practices have changed. We started off by exploring 5 domains related specifically to how each state conducts partner notification services. The first was STD epidemiology in general. I will not cover that in the rest of the talk. Tom touched on that, but we did review and aggregate together different surveillance data for all STDs. We then reviewed the different program structure for different partner notification programs. This included the number of health jurisdictions, districts, health departments in the state, where the partner notification personnel were based, what jurisdictions they were located in and worked out of, whether or not the partner programs were specific for HIV or STDs or combined, and how that worked. Also looking at state STD clinics and where people were referred for STD testing and what services, whether they're part of publicly funded clinics, whether they're part of privately funded or hospital-based clinics, and I'll show you some data on that. And then we explored some of the safety net settings in each state. We also explored disease intervention specialist roles in general, including what services the DIS provide, what training they're required. Again, do they do HIV outreach or STDs or both? How many per state and per jurisdiction, and how they work within the health department, including the surveillance staff to obtain the data. We also explored the specific methodology, including methods and timeframes that DIS reach out to index cases. We explored the specific attempts, whether or not it was through directly through DIS to contact partners, or whether it was through index case referrals or other methods, and we'll talk a little bit more about that. We also talked about or explored the specific method. So was it phone call, email, text message? Was it online through Facebook or through some of the hookup apps? And we also explored whether or not people were referred for PrEP and PEP. Finally, we also looked at different barriers to partner notification, and we asked each jurisdiction and state what are the major barriers that they see to providing effective partner notification services. All states in New England did have integrated programs for HIV and other STDs. Here in Rhode Island, we were one of the few states that really did have separate programs. They're under the same center, but they were distinctly separate. All state jurisdictions did have uniform partner notification protocols that applied across their entire state districts. The number of DIS per state varied from New Hampshire and Vermont, which had approximately 1 to 11 in Massachusetts, which certainly makes sense given the size of some of these different states. The range of responsibilities, however, did vary. Certainly when there's only 1 DIS officer in a given state, that they probably were expected to do a little bit more in terms of scope of their work. And they also varied between states in terms of which DIS officers did which. So here in Rhode Island, there are separate disease intervention specialists for HIV and others for STD. In fact, here in Rhode Island, we have 1 DIS for HIV, and then we have a couple others to do STD DIS. In most of the other states, it was combined, where DIS did both HIV and STD partner notification services. All teams, all DIS did work closely with surveillance teams to review index cases before reaching out to index cases. Most DIS were based in centrally located offices through the state, and most engaged index cases through phone calls, and we'll talk a little bit more about that. but most of them traveled to other clinical sites for interviews as well. In general, medical providers who diagnosed cases of STDs were required to report cases to the local health departments between 1 and 4 days after diagnosis. In terms of what notification methods were used by DIS, it was pretty uniform that the most common was that the DIS staff would contact partners directly. However, there were a number of other methods used by DIS. These included index patients themselves being asked to refer their partners in for testing and treatment, also through contract referral, which means that index patients were given a certain time frame to refer their partners in, and if they hadn't referred them in by that time, the DIS would reach out. I think importantly, there are a number of methods that were not used. That includes, at least at this time, email was not very commonly used, text messages were not very commonly used, and at the time, no health departments reported using Facebook. I will say again that some of this has changed, and I do know here in Rhode Island, specifically, we now do routinely use Facebook to reach out to index cases and partners as well. I think importantly, as many of us on this call probably know, that online hookup sites, apps, especially those being used by gay and bisexual men, but also in the heterosexual community, are very commonplace. Here in Rhode Island, we are using those now as well to reach out to partners and index cases, and I know that some of the other states are as well. In terms of syphilis and gonorrhea and chlamydia, the outreach methods were largely the same, usually through DIS-specific outreach, as well as through index patient referral. Gonorrhea, in terms of gonorrhea, there were a number of states that did gonorrhea partner notification. However, it was limited due to significant resources. In Massachusetts, they do not, at the time, offer gonorrhea cases due to limited resources. Here in Rhode Island, we did focus on gonorrhea in urban centers. However, we do not perform partner notification for all cases of gonorrhea in our state due to limited resources. And I know in many of the other states, and Daniel can perhaps mention this at the end, that there is a focus on specific gonorrhea cases, those who are higher risk, women who may be pregnant, high-risk gay and bisexual men, etc. But in a number of the states, not all gonorrhea cases are provided services to. In terms of chlamydia, you can see here that most of the states do not perform routine partner notification for chlamydia due to lack of resources. Vermont does provide limited partner notification services for pregnant women who test positive for chlamydia, and Maine focuses on doing so for those co-infected with HIV or gonorrhea or other at-risk populations. Massachusetts also did mention that they do chlamydia partner notification for providers who specifically request it for a given patient. In terms of where patients, partners of index cases tend to be referred, you can see here that it really is specific to each state, and each state approaches this differently. Rhode Island has one STD clinic, publicly funded STD clinic. It is a partnership between the local hospital system and the Department of Health. Rhode Island also tends to refer people to Planned Parenthood and other, in terms of HIV, other AIDS service organizations for testing. Connecticut has a network of 9 state-funded STD clinics, and tends to refer people to those sites as well as to other providers located throughout. The other states do not report any state-funded STD clinics and did refer people to a number of other clinics. In Vermont, federally qualified health centers. You can see Planned Parenthood is a common one that many states refer to, and then local providers as well. In terms of barrier for partner notification services for HIV and other STDs, pretty much the main, one of the main barriers was lack of resources across all states, and this certainly should not surprise people. Speaking from the Rhode Island specific experience, we are limited by staff. Again, as I mentioned on the previous slide, We are limited, especially for gonorrhea and chlamydia, and we're becoming more limited as STDs increase, especially syphilis and gonorrhea. The number of cases in our state has almost doubled for gonorrhea in the last couple of years. It's really put a strain on our DIS staff to reach out to all cases. Resources aside, probably the second most common barrier to partner notification that was reported is that index cases tend to give anonymous partners or not many names at all. And I really wanted to highlight that as the second probably main limitation aside from resources and funding for different personnel. But that's one thing that we've certainly seen here in Rhode Island and others commonly reported is that people just report anonymous partners. And that's specifically given that the HIV burden is highest among gay and bisexual men for HIV, for syphilis, and is really high for gonorrhea as well, that especially we've seen gay and bisexual men using a lot of the hookup apps, Grindr, Scruff, etc., where we've seen that they may not necessarily know all the names of the people that they're hooking up with. And these tended to be the barriers that were reported for all other STDs as well. Okay, so I think I'll end there. The major conclusions of our study were that each state tends to adhere to the CDC recommendations for partner notification services. However, each state really has worked in different manners to implement different practices and protocols, including different sites for referral. I think that was one of the most striking things, is that each state has really developed a system of STD testing and safety net services that they can refer people into. I think the final main conclusion of the paper was really that the main limitations and the main barriers that we all face tend to be lack of resources, lack of staff to appropriately engage all patients and interview all index cases, and also the fact that many, especially gay and bisexual men, tend to be having anonymous partners, which really limits the effectiveness of partner notification service. So I think I'll end there, and I'll also ask Tom and Daniel if there's anything that they specifically want to mention that may have been updated since the study was conducted.
Phil, I'll just
Tom, I'll yield to you first before I jump in.
Sure, yeah. The one other thing that I'd just like to share as an outcome of this study and the things that had surfaced, which Phil had just referenced, that much of the partner services work that we do is targeting the community of gay and bisexual men. And those challenges remain for us. And what we've done is continue to talk about it, and Yale School of Public Health has now initiated a research study which relates to how we can improve partner services from like a consumer lens from gay and bisexual men. So they're going to be doing a qualitative study and interviewing gay men who've been through partner services and asking them about their experiences as well as what their recommendations would be for an ideal partner notification system, keeping in mind that the role between the gay and bisexual community and state health departments, sensitivity around sex and sharing information, and what are some solutions that we can come up with that in the absence, or how we can improve our programs themselves, whether it be staffing or training, or website information or sharing information, and or being supportive of gay and bisexual men who choose not to opt into partner services and support them in doing their own self-notification. So that's underway, and we're hoping that the findings from that can really help inform us. So Danielle, I'll pass over to you.
Sure, certainly. Thank you. And thank you all for attending today. I'm really incredibly grateful to Dr. Phil and company for starting up this idea and looking at the region. You know, a lot of people think about Region 1 or the northern New England states, and you know, you kind of think it's all the same. As Tom kind of highlighted, there's two distinctions, you know, between Maine, Rhode Island, or Maine, New Hampshire, Vermont, compared to Massachusetts, Rhode Island, and Connecticut. But even among those two distinctions, I think there's a very dynamic difference within this region. And, you know, as Tom also highlighted, you know, one of our intents or purposes was to form as a coalition to get together as a consortium and really try to share best practices. We all kind of operate in our own way. I think that's safe to say for all the project areas that exist throughout the country, but even within regions, there's differences in practices and there's opportunities to learn. Surely, as the infrastructure of IPP has been removed, there's been an absence for our group, or at least our region, to come together and to try to begin to talk about best practices. You know, we all have syndemics, and we all have some border issues that are going on. You know, Vermont might be continuously one of the lowest in the nation related to chlamydia and gonorrhea infection, but our infections do come from somewhere, whether it's the leaf peepers coming into the state every fall, or, you know, folks that just get tired of this bloody winter that seems to never end. Folks will end up bringing back more than just a bumper sticker when they return from their respective vacations and back to the frozen tundra here. So again, I think there is something important in terms of trying to work collectively within your region and other partnerships. That's something that was afforded to us through the IPP structure. That's gone now, so it is. But there still is an opportunity for regions to get together and work with the players that you know and love and are inspired by. And I think the product that you see here today before you is kind of the hallmark of what can happen when you sit down and continue to work with your respective partners, whether it's across the country or within your region. Hopefully what you've seen either prior to this presentation, having maybe in advance read the journal article by Dr. Phil and company, you had a chance to really kind of evaluate what your own services are, what your own barriers might be. For me, this was a nice primer, to be reminded that the obstacles that we're facing, we're not alone. As we have an ever-rising morbidity, there are increasing challenges, you know. One of the latest updates, you know, as Dr. Phil said, you know, let's you know, are there some updates? Are there some new things happening? Well, one of the things that Dr. Phil highlighted for us is one of the common referral sites here in the northern New England region. 3 of the 5 project areas are referring to Planned Parenthood. What happens if the gag rule goes into full effect and Planned Parenthoods are affected? Here in the northern New England region, Planned Parenthood, about 40% of their budget comes through Title X funding. What if that source is challenged? What if sites have to close down? What happens in terms of our screening and referral practices? You know, we are looking at a time where there's ever diminished resources. We have diminished capacity for services in the field with the public health workforce that's diminishing. You know, once a robust infrastructure of greater than 500 PHAs across the land, federal DIS out there in the lands, now we're less than 80. We have daunting challenges ahead of us and a morbidity that is not patiently waiting. It's continuing to rise. We have a NOFO that we're all probably happily writing, or the ink is just drying and it's doing the rounds for approval. But within the latest NOFO for STD prevention, it's pretty clear that the days of chlamydia interviewing are gone. Gonorrhea, there is some random sampling of gonorrhea that certainly could happen, but and some interviewing should be there. But the priority really seems to be syphilis, and syphilis among 3 populations, but potentially really only 2 if you read the fine print in the NOFO. We have challenging days, folks, and I'm wondering, in the face of challenges that you're seeing, I'd like to begin to try to open it up to the floor and not just share the New England experience, but begin to ask folks whether you want to write in or open up the lines and have a discussion now, but to talk about your current range of DIS services and whether or not you're happy with what you're interviewing in the modality that you're using. One final thing before I fully ask that question, just to give you an update again, as Dr. Phil kind of prompted us to look at what has changed since this journal article came out. You know, hopefully what you saw is Vermont is well positioned to communicate and interview a number of morbidity. We still have a workable morbidity. This past summer, last summer, 2017, we had an HIV cluster, and that got a lot of attention. Given that our DIS service is about 0.2, guess what got the attention? And all the other infections, be it syphilis, gonorrhea, all of that had to fall by the wayside. Are we well staffed? Are we well positioned for the outbreaks that we're increasingly being asked to monitor or to rule out that are happening? I tell you, when we went through our experience and thought maybe we were looking at an outbreak and not just a cluster, we were going to have to call in the reserves. Fortunately, it did not come to that, but I can't say within the New England region that we haven't had to have federal teams deployed for outbreak response. It can happen. It might happen again. Are we ready? Are we well prepared? I don't know. So this is where I just kind of want to begin to open it up and have more of a dialogue with everyone, asking, again, just in terms of the infections right now, what are you interviewing, and what are the modalities that you're primarily using for interviews?
Daniel, is it okay if we start with the chat box questions since we have a couple already?
That would be great. That would be great.
Joan Chow says the article did a nice job of discussing innovative interventions to improve partner services, especially use of internet partner notification and mobile apps. Are any of the Northeast states working with website and or app developers to incorporate partner notification functionality since 2015?
Tom,
I think. Yeah, I'll jump in. Hi, Joan. This is Tom. Rhode Island has just initiated this process. We're learning from Maricopa County in Arizona, where they had developed an app, and I think there's some others around the country. They've been successful. They're continuing to do it, and we'll probably adopt a very similar model to them. The notification, though, is between the index case and the context they want to notify, where they get a unique code. It gives them access to that functionality, and they can send out anonymous messages. So we're in the midst of developing it. To be quite frank, we're running into a few little legal issues regarding HIPAA, but they're not serious concerns at all. But that's the direction we're going.
And I'd also say on a kind of a meta level, Dan Wolfeiler with Building Healthy Online Communities really has been doing some pioneering work here, Joan, as you may already know of, really trying to leverage those communities to be more friendly or open to the resources that we offer in our respective areas.
And if I can comment also, the app we're working on is going to be a broad-based sexual health app where you can find condoms and find Planned Parenthood, and just one piece of it is going to be for partner services. And we're integrating reproductive health into there also, of where to find contraception and make it as broad as we can from a sexual health perspective. But I can refer you to the Maricopa people who are extraordinarily helpful to us.
And I will say that we have engaged some of the app and hookup app companies and websites. The problem is that many of these websites and apps are international in scope, and so asking them for state-specific software or initiatives has been a challenge, and it's been really difficult to contact and engage some of these companies as well.
But it also does raise a larger conversation. You know, when working with these app companies, you know, should each and every individual state be going in trying to leverage their own contract, or is there something we could be doing as a national presence, a national front? Is there something that potentially NCSD could be doing in terms of trying to leverage DIS services through these apps domains? I know in the late aughts, before we broke to 2011, you know, there was a respective vendor that, you know, for a nominal fee, you could be on the site, but you also had to follow the sacred rules as established by that site, and it had a bit of a 3 strikes you're out. If you weren't following the rules or notifying in the way that they felt was appropriate, they knocked you off the site. But it seems an interesting dynamic when these vendors are, you know, essentially brokering contracts with various county level or state level or multiple states, when we all could potentially be going under one contract opposed to many. I know it doesn't maybe work for their business model. I just wonder whether there is a federal system in which we could nationalize our efforts opposed to being so individualized, but that also might be just wishful thinking.
Thank you all. We'll move on to the next question. Jessica Purser asked, in Tennessee, where I was a DIS for 4 years, we had about 11 DIS in the Chattanooga/Southeast region combined. It's about 1/10 of the population of Massachusetts. What's the difference in funding? My position was state funded through the CDC. Isn't that funding available to all states? We aggressively pursued chlamydia, gonorrhea, syphilis, and HIV for all populations because we had the staff. Can you all speak to that?
Yep. Whether it's NACCHO, AASHTO, or NCSD, I think a survey has been done in terms of the proportion of federal versus state contribution to DIS positions. A number of programs are fully federally funded, and if you are exclusively federally funded, it's dependent upon those funds to what positions you can create. Vermont, for instance, we had a lower award even than Puerto Rico. CDC has done their best to bring up the minimums, but there was a time where we had $172,000 for STD control efforts. Granted, there is a new floor with the new grant. Some of that has changed. Part of the thought, though, too, is looking at the DIS infrastructure and certification and reimbursement model, so that even if federal funds isn't enough, even if state funds aren't enough, there eventually, and NCSD has been a part of this collaborative, there will be a DIS certification that you can go ahead and have your DIS certified, and then it would be a reimbursable service. However, I will ask the question, or point out that you also need to have enough of a workable morbidity to sustain that sort of FTE. But there are various options for funding levels. It depends upon what you have at hand between state, federal, or the forthcoming DIS certification module. Tom or Phil?
Well, my only comment, and I appreciate Jessica bringing this up, is twofold. I do think across the country there's differential investment in DIS through state dollars and federal dollars. There's also differential investment, I think, of placement of federal employees, which makes things very much off kilter. And I think with growing syphilis rates and that being a priority for many states, it's creating even more of challenges of having state health departments do comprehensive partner services. So it's something to look at in terms of across the board our ability to address these diseases. I think the second piece too, and I'm glad Jessica brought this up, is that, well then, depending on staffing, how effective are the services? And I think one of our goals as a region is to compare our metrics across states for all the different diseases. But as you can see from Phil's presentation, our models are so different, sometimes it's apples to oranges, but that's a challenge and something that we'd hope that if some states have particularly high metrics, that they're doing something different or better than the other states that we can learn from. But that's a natural next good question and something to explore.
And the only other thing that I'll add is that different states sometimes prioritize different STD outreach initiatives or approaches. So certainly partner notification is considered a very high priority, but there are also other high priority approaches that some states do focus more resources on and potentially less for DIS.
Thank you. It's been a good discussion around not only internet partner notification services, but also with funding, but moving back toward using apps and other software. Karen Geisiker asked, has NCSD approached the software app companies to establish a national approach versus a state-by-state approach? And for this, I'll hand it off to Neil Rana, my colleague here at NCSD. He's the Health Equity Manager and can speak to this question.
Hi everyone, so I can briefly provide an answer to that. NCSD actually partners with Building Healthy Online Communities, which is led by Dan Wolfeiler from California. I believe Daniel mentioned him. And we have approached some of the major app companies and the hookup app companies to incorporate STD testing reminders and advertising for different health departments, and we're continuing to expand that partnership. So BHOC is doing a lot of great things in that area, and NTSD is partnering with them and looking to expand our services much more. So stay tuned on updates for that.
Awesome. Thank you, Neil. Did anyone else have other questions, or I see some folks typing, or can they answer any of the discussion questions that are posed right here on the slide? Do you have anything else to add?
And I wonder about maybe posing the second question, since there wasn't any chiming so far on the first one. But just in terms of your range of DIS services, as the morbidities have risen, have you been forced to change your prioritization or the range of interviews that you've conducted? Ooh, that might be getting some reaction, or... Wow. Okay. So thank you, Jessica, for that. Tennessee has added hepatitis B services as those have risen, and certainly we are seeing some more acute hepatitis B this day and age. Did that, Jessica, did that mean something had to go for that to be added, or? Nope, just added our duties. Yeah, thank you. And that's part of the problem here. You know, we have ever increasing pouches. You're never going to be able to close them all, right? And you have a greater portfolio. So certainly the challenging days here are upon us. As we have rising morbidities, I think our DIS are being asked to do more. Certainly a challenge. Whoa. So Leandra, we got a lot of buzz coming in here. Do you want to take us through to Karen's question?
Sure. Yeah, Karen again chimed in and said Colorado is focused on HIV and syphilis, and we are part of the SURGE study, which is the strengthening U.S. response to resistant gonorrhea. That's awesome. And she said we now have 2 DIS focused on resistant gonorrhea, but both the SURGE-specific DIS are pulled into other diseases. So I guess that definitely does speak to certainly a challenge that I feel a lot of jurisdictions are most likely experiencing as well, another barrier with having DIS being pulled in all kinds of different directions and having their capacity diminished a bit.
Yeah, and I think that's one of the great hallmarks or marketing of whether it's the public health advisors or field DIS that we see that we have in our respective states. This is a highly deployable field staff. You know, classically we're trained on chlamydia, gonorrhea, syphilis, HIV, what have you, but there are models out there, whether it's Ebola, foodborne, DIS have been deployed to other domains because of the central skill set that our DIS have that are easily deployable. And I love, you know, those DIS, they're pulled in different directions, but they're ready and prepared for resistant gonorrhea when and if we think that we're seeing it. Yeah, very interesting and good to know that folks are thinking ahead and getting prepared for resistance when it comes. Dr. Chow here asks us, for states that do chlamydia follow-up, has there been an evaluation of chlamydia follow-up to help deprioritize them in favor of following up syphilis cases? I don't know of anyone else that has done chlamydia evaluation. What I know with regards to Vermont, you know, last year we had 12 cases of infectious syphilis. Total, including PNS, we had 29 cases. So, you know, syphilis automatically, when it comes in, it's ratcheted up as a priority. Chlamydia is in the background for DIS services. when syphilis isn't happening or gonorrhea isn't happening. Maybe not the best approach, but basically what we had to think about in terms of our evaluation is the potential sequelae related to chlamydia. If we're going to interview, when we interview, though we know we're not going to slow the endemic of chlamydia, how do we reduce the potential sequelae? And so reproductive health in pregnant women were prioritized. I'm not sure if anyone else has evaluated per se chlamydia. Rhode Island?
No, we haven't.
Okay.
Jessica Fraser-Williams
Yep.
chimed in. Hi, Jessica, and talked about her experience in California, saying that they have a number of local health departments that have had to significantly shift their work towards syphilis among women, as they have seen huge increases in congenital syphilis. In some cases, they've had to eliminate partner services for early cases among MSM. They've tried to, they've tripled in stillbirths in the last year. Wow, that's very alarming. So this is a large area of concern that is requiring reprioritization of DIS time. And of course, the number of staff simply do not meet the demand, which I'm sure, again, a lot of other areas are dealing with the same issue, and had to have a conversation around reprioritization and what that looks like and what will be prioritized. Karen also chimes in again and said, are DIS in your state centralized or decentralized? In Colorado, all are state employees and all are in Denver except for 2 that are regional. We have a total of 10 when fully staffed. Which, do you all have anything to add to that? Can anybody chime in about that? It's a great question. Thank you.
Well, I can speak for Rhode Island. I mean, Rhode Island's a very small state. It takes about maybe 45 minutes to drive across. Everything's very centralized here, and the DIS staff here in Rhode Island do go off-site to different clinics around the state, but everything is very, very centralized.
Vermont is centralized as well. Our 2 DIS were based out of Burlington. When we had another DIS, I did west of the Green Mountain, or east of the Green Mountains. Barry did west. But we still canvassed the state from Newport to Bennington. We covered all out of Burlington.
Thank you. Rebecca Scranton chimed in and said, this is a little off track, that's okay, Rebecca, we have some time.
We're good with that.
Given the high case volume for chlamydia/gonorrhea, I don't think we can combat chlamydia, gonorrhea through DIS and targeting apps alone in our preliminary outreach to clinics to improve EPT. We've noticed many nationwide drugstores/pharmacies and FQHCs that offer STD testing have policies that prohibit EPT distribution. Given that these venues serve key populations for intervention, we would like to see these policies changed. Have any other jurisdictions seen similar issues?
Well, this is Phil. I 100% agree. Certainly, we talked about partner notification, but in my opinion, certainly one of the biggest efforts should focus on routine screening for STDs in general, and especially among primary care docs and in the medical community. So I think that aside from partner notification, actually testing really needs to be the 1, 2, 3 focus, and especially given that many partners are anonymous and many people aren't referred in, and just talking about how addressing STDs in general. Expedited partner therapy, absolutely. It's legal here in Rhode Island, and we do use it. At our STD clinic, we have found in general that partners are willing to come in. And I think we use, and my sort of approach to expedited partner therapy has sort of been as a second line, meaning, of course, if we can't get the partner in, it's always better to get the partner in so we can test them, not just for chlamydia, that's usually what we're doing EPT for, but also for gonorrhea, HIV, and syphilis. If someone absolutely refuses to come in, or if there's certainly an extenuating circumstance, then we definitely reach for EPT and do it.
And I know our New England counterpart, New Hampshire, also, when there was an outbreak with gonorrhea in New Hampshire. For non-MSM populations, they did go the route of EPT for gonorrhea as well. Back to the question, though, I think one of the things is targeting gonorrhea and chlamydia isn't necessarily going to slow it down or bring it down. It comes back to what Phil said. I think screening really goes a long way. We need to leverage that HEDIS measure and try to ensure that it is being done. While it is screening for chlamydia, dual assay, great way to also be picking up our gonorrhea. I also like to look at leveraging of PrEP, that if, we can get more folks onto PrEP that need to be on PrEP, we're looking at a built-in targeted screening there, especially if providers are following the gold standard of synchronized testing every 3 months, both HIV and STI site-specific testing. Targeted screening really goes a long way with these endemics.
Thank you all. Some responses to previous questions. I'll read those aloud before jumping back into the questions. Karen said, in Colorado, chlamydia cases are only managed if they are HIV positive with a viral load or co-infected with new HIV or syphilis case. Jessica Purser responded to Joan, saying chlamydia cases are the lowest on the totem pole, but there's been no evaluation. Responding to Karen, she said the DIs there are decentralized. She was a state employee but covered 3 rural counties near Chattanooga. Jessica Fraser-Williams also jumped in with the previous question, saying that California is also decentralized with the 8 field-based state DIS providing mentorship and surge capacity. Karen also said that EPT for MSM is an issue that they often discuss as well. So thank you all for answering these questions and chiming in. Going back to the questions, though, Charlie Ravens from NCSD. Hi, Charlie. He asked, does using FaceTime and Skype for index patient interviews look like a viable method, especially in geographically dispersed states?
So I can answer this.
Always raising the bar. Go ahead, Phil.
So I was going to say, absolutely, it's a fantastic idea. And we do some of that, and Tom can talk more. We do some of that for TB interviews and directly observed therapy. But I think the one thing to keep in mind is, and the thing that I think limits FaceTime specifically and Skype, is the HIPAA compliance of it, and to make sure how do we know it's secure and whatnot. And that's been a limitation as we've looked at and talked about things like apps and different platforms. Is ensuring the confidentiality and HIPAA compliance, and that's been a major barrier. But in general, I think it's a great idea.
Yeah, and I do wonder if it's a tool that we could go to. I mean, I'm thinking about an interview that I had the other day, a guy, just finding out his HIV status, and I was there in person, and we had talked about it, but I was asking about an interview, and, he said, I would like to meet with you in person, and I said, great, I can get there in 10 minutes. Well, great, because, he was in an inpatient hospital. I could get up the hill. I could go see him right then and there, but what if he was, 3 hours away? The key line that he said to me is, it's just that much easier for me to do an interview if I can see a face. So, Charlie, yet again, a great mentor, thank you. What if in that situation I could say to him, I can't get down there. It's 1 o'clock right now. I wouldn't be able to get down there today to meet with you, but we could switch over to FaceTime right now or Skype. Would you be open to that? I think as technology advances, we need to think about the tools in our toolbox to do our DIS services. So thank you for that idea. Of course, as Dr. Phil brings up, we need to think about HIPAA compliance. But also, as you highlight, Phil, and Tom maybe could attest to, there are ways in which it's already being applied. Maybe it's in TB control efforts. Could we use it with some of the work we're doing now? Great idea.
Thank you. Patricia also responded and said that in Michigan, DIS are decentralized. Detroit STD staff are centralized. Michigan DIS have addressed increased LGV and HCV cases among people living with HIV, engaged in HIV medical monitoring projects. will engage in D2C, data to care, and DIS are available for HAV outbreak. Thank you for that, for responding. I wanted to tackle another question that Jessica Purser posed and said, has there been talk of doing a nationwide survey like this to get a complete picture of DIS work? This is an excellent question. I will say that it is on NCSD's radar as far as looking at like workload and workload evaluation for DIS nationwide. It is something that we have had talks about with our DIS advisory committee, who we use a lot as sounding boards for different projects and ideas coming through the organization that directly involve DIS. So I did want to let you know that it is on our radar, and we acknowledge that it is a super important topic. So thank you for that question. Karen, I know we're running low on time. We'll take one more. Karen said, is anyone working with primary care clinicians to enhance their ability and comfort in doing sex health histories? Also a very important question.
Yep, here in Vermont, we've been working with our maternal and child health program, trying to promote bright futures as well as sexual health competencies. And it really does seem to be going a long way. The greatest effort for us is that partnership with our maternal and child health program, going at this from two different angles, certainly has given us a greater reach.
And I'll say in Rhode Island, this has been a primary area of interest. There are, as Tom alluded to, the AIDS education training centers across the U.S., AIDS education, the AETCs, do have a focus on HIV, but also on STDs and raising sexual history and educating the clinical workforce, including primary care physicians. So I know here in Rhode Island, we do a number of CME lectures throughout the year, focused on issues like STDs, like taking a sexual history. We've also had some dedicated funding that we've engaged our local community health centers, our fairly qualified health centers here in Providence, to do some different educational events. So there are a number of states here in Rhode Island and elsewhere that are really focused on improving sexual education, and I think it is a super important topic.
Thanks, everyone. I think someone may have put us on hold. Sorry about that. Thank you all for being here engaged with the webinar. I really appreciate it. Since we are short on time and it is 4 o'clock, I will go ahead and end the webinar. Make sure that you fill out the evaluation. It's very, very brief, maybe about 5 minutes. So just to inform from the webinar. Thank you also to our producers today, Dr. Ian, Daniel, and Tom, for their insight and for sharing their articles. I've shared their emails here as well as my email to NCSD if you have any questions for them. Neil has also posted the evaluation. Thank you so much, everyone, and I hope you have a wonderful day.